Thank you.
Yes. So, hello everyone. Welcome to Exchanges in Primary Care. This is a session. It's an informal session. We're fairly informal here. And it's a group of practitioners, public health practitioners, primary care practitioners who've come together and who share their experiences uh, with the larger community. And we just learn from each other and learn from each other's experiences. And today we have our very own Alok. Alok is a doctor from Bombay, and he has worked in many places, which I'm sure Alok will share. And he's a BHS now, and we are very happy to have him. Today we'll be talking about his experience from Swasthya Swaraj. And so, without further ado, Alok, over to you.
Thank you so much. Thank you. It's so nice of you to introduce me, and I'm really happy that so many people came today. And is it all right if I start sharing my screen now? Okay.
Yes.
So we've got my good friend Shubh, who has also come. He's from the US, and Alexandra, she's come from Scotland. And they both actually come to Swasthya Swaraj, so I'm really excited to hear from them as well. Just give me a second. I'm just going to start sharing my screen now. I hope that
Sure.
you guys can hear me. And if you want me
Yeah,
to,
loud
I
and
can
clear.
be a bit louder as well.
I think we can hear you fine, Alok.
Thank you so much. Thank you. So is my screen visible now?
Yes, it is. Yes.
Oh, great. Okay. Oh my God, Jarvis has come in from Australia. Jarvis is a very close friend of mine, and he's planning on coming to visit me soon. So that's very nice. Thank you, Jarvis, to have come in. So yeah, uh, so I'm going to be talking about my experiences in Swasthya Swaraj, where I was working for the last 15 months before I joined BHS. And so Swasthya Swaraj is working in southwestern Odisha, and the work there is mostly primary care, but one of our clinics is slowly transitioning into secondary care. So it's in the eastern Ghats of India, and it's quite heavily forested. And so we work in about 120 villages, and it's spread over quite a big distance. And the block population is of about 80,000 people. And most of the people whom we serve are the Kutia Khons, who are a particularly vulnerable tribal group. And so I'm going to skip to where I talk about. Okay. I think I missed that slide. I'm really sorry about that. If you give me 1 second, I think I uploaded the wrong slide. Just one. Give me 1 second. I'm really sorry about this.
No
Uh,
problem. No problem. How long were you in Swaswaraj for, Alok?
15 months from December of 2024 to uh, February of 2026, but it looks like because I was editing this slide on the work computer here, and it may not have been saved. I'm sorry about that, but it doesn't make a difference. It's only one slide that is missing. But so about the work that Swasthya Swaraj is doing, Swasthya Swaraj is quite deeply involved with the community there, and there are five clinics that are mostly nurse-led. So there are a lot of nurse-led consultations that take place, and we train the nurses at nursing school, which is called the DCHP, or the Diploma in Community Health Practice. And we in all of these five clinics, uh, we get about 10 or 15 patients a day on average, most of whom live in villages where healthcare access is a huge challenge. And at these smaller clinics, there are also doctor days where we have more people turning up. And so apart from these five clinics, there's also a slightly bigger clinic with about six inpatient beds, and the facilities there are quite good. And there's a lab with quite extensive services, and we've got an X-ray machine as well. So we indoor sick patients there who are unlikely to get referred to higher facilities. And apart from the clinical care that is provided at these clinics, we also have many community programs. So there's the rural crash program, which is run in more than 60 villages. So there are more than 60 crashes, and each crash has about 10 to 15 enrolled children. And the crashes run from 9 to 5. And the children are provided nutritious meals, and they're also provided with sensory motor play to promote cognitive development. And they're also routinely screened for diseases, and growth monitoring is done to see if uh, if there's malnutrition or if there's failure to thrive, or uh, and there's also a good referral link between the crashes and the clinics in case children require uh, access to the clinic for diagnostics or for further treatment. Apart from the crash program, we've got the health promotion in schools. So we have uh, about 15 primary and secondary schools that we work with, and we go to the schools, and uh, we our nurses will mostly take a lot of sessions about uh, how good health promotion practices and practices for improving nutrition. And then there is also a program for livelihood skills, uh, and that mostly focuses on adolescent girls. And then there are Tulsi clubs, which are run by the adolescent program, in which young girls are encouraged to become independent financially, and they are taught entrepreneurship skills, and they're given financial literacy so that they're able to uh, you know live independently, so that it helps delay early marriages, and uh, it gives them a voice in the community. Then apart from these community programs, there are also now.
Sorry, Alok,
Yeah,
are the slides moving? Because we are able to see the
yeah,
second
no,
slide only.
the slides are not moving. I'm still just giving you a context and a quick introduction to what the work that is being done by Swasthya Swaraj. I unfortunately have not put this particular slide on the presentation, so I'm just speaking extemporaneously. But uh, the so we've got these community programs, and so we do witness a lot of migration, and that is one big challenge that we encounter on a daily basis. And in an informal survey that we had done, we saw that about 40% of the amongst most households, there are people who migrate to the southern states for uh, informal jobs. And this includes work as daily wage workers or in the restaurant as waiters. And most of this is distress driven migration. So there are many houses in which there is limited irrigation, and it's difficult to till small parcels of land. So, and then there's also the compounding factor of illiteracy or poor access to education, which leads to more and more people seeking work elsewhere in the city. And so young males tend to migrate a lot. And in the city, there is unfortunately not very, the problem is that there is poor housing in the city. So they end up contracting many illnesses there during the time that they migrate to the city. And then also when the left behind families, they face greater burden because of decreased social mobility, because in general there is a large reliance upon the males to facilitate healthcare access. So then there is social isolation is, as a result of that as well. And then there's also a big uh, distinction between the uh, different subcastes or the different caste groups that exist there. Like in the case of the STs who make more than 90% of the village's composition, they usually tend to have lesser land. They also have more migrants per household, and they're also more prone to contract infectious diseases. And there's also increased mortality from infectious diseases because of poor healthcare access. Whereas the scheduled castes, they relatively tend to be more well off. And but there is also a very big contrast between the incidence of sickle cell disease amongst people who belong to the ST community as opposed to people who belong to the SC community, with the SC community having more than 50 times as much sickle cell disease as the ST community. And one reason why this might be the case is that there is increased consanguinity amongst the SCs, and that may be a contributing factor. So there isn't much work that has been done to really find out what could be some other contributing factors that is causing such a stark contrast to appear. But it looks like this might be an important factor because quite a lot of the scheduled caste people there marry amongst first or second cousins, whereas this is really not the case amongst the scheduled tribes who tend to marry with people who belong to different families. So there's also an increased incidence of non-communicable diseases, including stroke. And one reason why could be because of their relative social affluence. So my first case is going to be about Ranjita Maji, who and I've changed all the names in this presentation. Uh, but Ranjita was she's a 28-year-old female, and she's the mother of a 1.5-year-old child. And she is a seasonal migrant laborer in a textile plant by occupation. And she presented to the clinic with a chronic cough of 8 weeks duration, with fever and night sweats. And she also had a 1 week history of left-sided chest pain, which started as a sharp stabbing pain, and then it evolved to become a continuous dull aching pain, which was worsened on coughing and deep inhalation. She also complained of having gradually progressive breathlessness for 1 week, and her child, who was also brought to the clinic with her, had high-grade fever with chills for the last 4 days, which was intermittent in nature. And the child had been feeding poorly, and the child had also been having multiple episodes of vomiting for the last 1 day, and the child had splenomegaly. So her past medical history was significant because she had come to the clinic 2 years ago, and she'd had fractures to the right ulnar shaft and the right eighth and ninth ribs, and that was 2 years ago. And she had said at that time that these injuries had been because she'd fallen off of a motorbike. But only upon further inquiry at this clinic visit was it found out that she had sustained these because of domestic violence at the hands of her husband and her in-laws. And this was at the time in her life when she was pregnant with her daughter. She had been 3 months pregnant and she had been subjected to these injuries. So this is what her family tree looks like, and I'm going to quickly uh, run through it. So this is Ranjita, and Ranjita and her husband are now separated. They don't live in the same household anymore, and they've got a 1.5-year-old daughter whose name is Mala. And so Ranjita's mother passed away when she was quite young, and so she's got 4 siblings. She's the eldest of 4 siblings. She's got a younger brother who is married and who has 2 children, and she's got she had two younger sisters who passed away when they were very little. They were less than 1 month old each when they both passed away from fevers. And so Ranjita now lives with her grandmother on her father's side, whom she's quite close to. And her paternal grandfather passed away a really long time ago. So Her household now comprises of herself, her paternal grandmother, and her daughter. And she's got a hostile relationship with her husband, and all of that hostility is directed towards her. So her in-laws and her father as well. Her father does not get along with her at all, and we'll see why in just a minute. But at the moment, it's just the case that she lives with her daughter and her grandmother, and she's got a lot of hostility coming from her husband and her uh, in-laws. So yeah, so I'm going to run through a quick assessment of her uh, of the social factors that contribute to her illness. So she's a single mother, and she does have to deal with a lot of domestic abuse. Fortunately, she does not live with her husband anymore. She hasn't been living with her husband ever since her daughter was born. But she does suffer from a lot of ostracization in the community because she's a single woman and she lives with her grandmother. So her grandmother owns a very small amount of land, and they really don't have much of a formal income. And there's very little access to nutrition. And in a village, there's no safe drinking water or sanitation. And so their house comprises of it's an indigenous house which is made out of clay and wood, and it is damp. And there are three. Well, so the grandmother and Ranjita herself, and also a daughter. They live together, and she lives in a really remote village, and there's lack of access to healthcare, with the nearest bus stop being 10 kilometers from her house. So she has to walk all that distance just to get to the bus stop, from where she has to take the bus that is uh, the bus that goes down to the clinic. That's 15 kilometers away. So 15 kilometers on the bus, and then there's a high indirect cost incurred during the treatment of her tuberculosis because there is loss of daily wages, and she does have to pay for her transport. So there's also delayed access to care because she goes to traditional faith healers who are called guru gunyas, and they are in indigenous society. They were traditionally people who had a great knowledge about herbal remedies, and so she goes to the guru gunya a lot in order to seek care from him. But unfortunately, she hasn't been getting better because of the treatment that she has been receiving from the traditional faith healer. Then on examination, she was found to be quite pale, and she was also tachycardic and tachypneic, and she had forced repetitions in her bilateral upper zones, and in the left lower zone, the air entry was absent, and there was dullness on percussion. So it was found that she had pleural effusion. Uh, so they were both admitted, and the daughter had severe malaria, for which she received intravenous artesunate, and for Ranjita, we tapped her pleural effusion, and we started her on anti-tuberculosis treatment. And her course, both of their courses in the ward were uneventful, and they both got better. So, uh, so at discharge, I asked her whether anyone from her family was going to come and take her back home, but she said that she wasn't really expecting anyone to come. So her grandmother, she's been living with her for the last 1.5 years, but she's quite old now. And so her partner has abandoned her, and so she's been living with her grandmother. And so because her mother died in the bus accident, and then she's mostly been raised by her grandmother, who's quite old now. She's actually about 80 years old now. So Bikram, he was actually also a migrant laborer who had also gone to Tirupur, which is in Tamil Nadu, where there's a lot of textile work. And so he promised to marry her there, but they were from different castes, and then so the parents did not accept her. And then she was pregnant with Mala when he forced her to abort, and then he had beaten her up at the time, and he'd beaten her up quite a lot, and she actually also sustained fractures at the time. to her ulna and to her ribs. And so what happened afterwards was when she was living with her grandmother, when she gave birth to Mala, she sort of slowly started, you know, working in the field and the forest, and they did have a good harvest, but then there was failed crop, and she wasn't receiving any services from the government, no subsidies from the government, and there was not really any local livelihood for her, so she wasn't really getting paid much. So that was Mala's case, and if we like, we can do a quick discussion about everything that we just saw. So I would really invite everybody to uh, share their views about what we just saw. And like I've highlighted some points that we can probably talk about as well.
Anyone can come in and share your views or if you have any questions. Alok, maybe you can go ahead and share.
Okay, great. Dr. Sanjana, do you have anything that you'd like to talk about?
Yeah, no, thanks for sharing this, Alok, and it's very commendable to have made a note of all the multiple determinants that actually influence the health. And it's a reminder that from a hospital setting, you can do only a limited bit. That limited bit is also very valuable, no doubt. But just that for poor, because there are so many different barriers that they face, then which is why the value of primary care becomes really powerful. So I was just reminded of that. But maybe I'll come in later as I listen to more.
Thank you so much, ma'am. That's really valuable that you said that, ma'am. And because we've got some friends who joined today who are actually some friends of mine from college who actually are MDs now. And one of the reasons why I asked them to come was to sort of try and see how we're trying to see things in a multi-dimensional way. So, outside of the clinic, trying to see what is going on in the community. So thank you so much for that, ma'am. Would anybody else like to say anything about this? Thank you so much for that, Tanmay. That's a great point that you've made. Thank you so much.
Hello?
Hi. Hello.
Yeah, Dr. Aalok, can you hear me?
Hi, Milinji. Yeah, we can hear you. Thank you so much. Yeah.
Great. Actually, if you make a combo of all this, the discussion point, Dr. Sanjay said that these are the determinants. It's actually, I take it like that Garibi and these chronic diseases have a close relationship. Because the education is affected, health is affected, nutrition is affected because of poor livelihood. So poor livelihood, and secondly, there is a lack of resource availability to these affected people in such a geographical area. So this all is a cumulative synchronized with each other in a way like no big change is seen there as for the health, because it's migration is because of, again, the poverty is in the center. If they have the livelihood, employment, industry in their own local area, probably they won't be migrating to other states. So it's a kind of a very comprehensive problem. So in our setting, we can address mainly the health issues and to
Right.
some extent the social issues.
Right.
to some extent, but limitations are always there. Challenges are quite big. So really interesting presentation, this one, the case one study.
Thank you so much, Dr. Milin.
Yeah.
That's so nice of you to say that. Thank you very much. And I agree with everything that you say, and the fact that it's a societal illness more than anything else. And as you said, we do our best, and we try to help them in any way we can in the clinic. But it's so interesting to know that there's so much work that is being done outside of the clinic as well. So we can learn many things from that. Thank you so much, Dr. Milin.
And the other part is women are more vulnerable in such a setting. They have to work in the fields, they have to work at home, and same time they have to, a lot of social stigmas are there. So that's the really big problem. But anyway, just please carry on. Yeah.
Would anybody else like to discuss this a bit more? If anybody would want to talk about, thank you so much. I think we've got somebody who would like to say. Yeah, hi Bhargav.
Hi there. Actually, I want to share another thing. When I was doing internship in Swasthya Swaraj, I spent 1 month there and I observed, I don't know if you observed or not, it's in Sylhet, near this clinic, you can't find any shop like regarding fruit and vegetables, but there is one shop of foreign wine liquor, and all the packaged item like the ready-made food, all the preservative foods you can avail there, but you can get the fresh vegetables. You can get, so this economical system is working like this, and you are there nudging you to consume bad food. I think that thing also leading to bad health to this community.
I agree with you. I agree with how we are witnessing this big transition in terms of livelihoods as well, and we've got this ease of access to a lot of consumerist goods. Like as you're saying quite correctly, even in small village shops that are quite remote, you can still buy toffees and a packet of chips for quite cheap, and a lot of children are eating such things, and it's quite sad. So it's going to lead to a triple burden of diseases in rural and tribal India. We're going to have a lot of infectious diseases, but we'll also have non-communicable diseases of this sort, and and they're definitely on the rise. There is no denying that. So, would anybody else want to add anything, or should we just proceed to the next slide, which the next discussion?
I think we can proceed to the next discussion.
Okay, great, thank you. So the next one is about a young boy, and his name was Amit. So we've changed names, and he is a 5-year-old, and he lives. He had actually come from a remote village by the name of Poladumer, and it's a really small settlement of about 40 houses. And actually, if Shubh is here, he will tell us that we'd actually visited their house as well. I think, that Shubh was here around the time that we'd gone to visit their house as well, and it's in an extremely remote part of the, so then he'd actually come to the clinic with having sustained burns to his anterior neck, chest, and abdomen. And what had happened was the poor boy had fallen into a cooking fire, and then his shirt, because it was made out of a synthetic fiber, had fabric, it had caught the flame. And so it's just, so actually these are some photos I put up, and if you can kind of make it out on your slide, this is the village of Poladumer, and I see if we can magnify it just to sort of see how. That's Poladumer right there. So it's in the middle of a really dense forest, and they've now got. Actually, they were paving the road that leads up to the village when I'd left. So it's actually going to become better for them, but it's quite remote. And this is what the sunset looks like from up at the hill. And so you can imagine how remote it was. And so his parents hadn't been home, at the time that this incident had happened because they'd been out in the forest to gather leaves. And his grandmother had carried him to the clinic and she provided some sort of primary care before bringing him. And at presentation, he was severely malnourished and also dehydrated, hypoglycemic, and tachycardic. And he had about 20% superficial burns. And so we managed that by giving him fluids and we managed his wounds. And because he was so malnourished and therefore immunocompromised, that leads to two big challenges because he's at an increased risk of acquiring infections and also because of how nutritionally intensive it is to make a new layer of the skin. So the nurses had actually fed him this nutrient-rich concoction that they make out of cereals and milk and eggs, as well as a few other things. And we'd continued doing his dressings and he'd gotten better. It was surprising that his parents hadn't come to see him on day two. So I asked his granny why, and his granny told me that this was probably because they hadn't returned from the forest. So I decided to walk to his house, and his parents had returned by then, and they were happy to know that he was doing well. And they told me that the reason why they hadn't been able to come was because they were busy in the forest, but that they were going to come the same day. So then they did come, and then he was doing quite well. But on the fifth day, he started running a fever, and we ruled out all the other causes. So it looked like there might have been an infection of the burns wound. So we managed that with antibiotics, which we had prescribed quite rationally, and then the fever had subsided. So he was doing quite well for in the ward, and so he recovered well, although he did not gain any weight at all. But his wounds did heal quite well. So we discharged him on oral nutritional supplements. And when I went to his home a few months later, we saw that his wounds were all right. And even though he put on only a little bit of weight, he was still quite severely malnourished. And what he does nowadays is he helps his parents out and he goes to the mountain farm to tend to their crops, or he goes down to the stream sometimes to fetch water. There's no Anganwadi in Poladumer, and so therefore it is difficult for him to go. So we do not even have, to the best of my knowledge, there is no crash in the village. So or maybe there is, but I can't remember anymore. But unfortunately, he doesn't really have like a daycare center or a preschool that he visits every day. And he doesn't also have access to government nutrition. So the public distribution scheme is through which rice is provided, and there is intermittent access to that. So some of the points that I wanted to discuss was that now, especially in Kalahandi, burns management is a big challenge, even in big hospitals, because there aren't many specialized burns units in many districts. Especially in Kalahandi, we don't have a separate burns unit in the government hospital. And even if there are specialist units, there isn't much cleanliness. So a lot of patients end up developing sepsis and a lot of them also die. So I was thinking about what role primary care can play in this situation. And if anybody has any opinions about dressings, because a lot of dressings for burns patients tend to be quite expensive. So is good old fashioned gauze enough? And is there much research that has been done about the role for other sorts of dressing materials? And then there's also the added challenge of malnutrition. So, whether there has been any experiences amongst the doctors here about whether culturally appropriate foods can be locally sourced, or whether stuff that has been formulated in a lab is likely to be more helpful. So yeah, if anybody has any points that they would like to add, I would be very happy.
Yeah, Dr. Alok,
Hi.
we used to use this sofra tool, the paraffin wax dressing, keeping the wound clean and at the same time easy to change the dressing without causing the healed wound the further damage. And somewhere I also read they used the boiled potato peel,
Mhm.
the potato peel, the trial, the one. If you run out of such material, so boiled potato peel also can be used to cover the wound.
Oh, that's fascinating.
Yeah, this
Thank
I
you.
have.
Thank you.
Yeah, I have read somewhere about this also. Like in case of you are running out of any supply of those sterile pads and all that, that also can be used. So this is perfectly sterile, can cover the wound, and you can frequently change it. A nutritious meal and covering with the antibiotics because the shock and the pseudomonas infection is quite common in the burns cases. So covering with that broad spectrum antibiotics as well as maintaining the state of shock and the pain and that adequate hydration is there not to let the renal shut down. So this kind of complications can develop and depending upon the percentage of the burn, the management is all depend all on that.
Right. Yeah, that's so nice of you to say that. Thank you so much. Dr. Sanjana, do you have any insights that you would please like to share with us?
Yeah. Thanks for this, Aalok. So I was thinking that burns are a very difficult condition to manage. Tertiary care has its own challenges in terms of maintaining asepsis, the high risk of infection. But I was also thinking even in primary care, theoretically one could imagine primary care as a place where there is a lot of space and relatively better hygiene, lesser risk, but uh, that is also it's difficult. And also in homes, you know, and I'm more familiar with homes in rural South Rajasthan, where the homes also are not so well organized. We talk of it more when we are talking about postnatal care, the need to maintain cleanliness, hygiene, less risk of infection. But because they have only this one room, which is so packed, uh, the risk of infection still stays high. So I would say that primary care has a potential to be more, upgrade, upgraded for being able to handle such cases. But it would need more, changes in the structures to be able to meet the needs of a person with burns.
Thank you so much for that one. Thank you very much. Would anybody else like to say anything? It looks like maybe we can skip to the next one. The next slide. Okay. So the third one is also mostly about malnutrition. So it's also about sick. So Sabitri Naik, she's a 4-year-old. She's from a village only 5 kilometers from a big clinic, which is well connected by road. And then she's a scheduled caste by uh, she was born of a second-degree consanguineous marriage. She's developmentally normal and immunized till date, but she's severely malnourished. And she presented with 1 day history of severe pain over the right thigh. She was found to have pallor, mild icterus, and splenomegaly. And she had an HB of 7, a bilirubin of 3, and 4% reticulocytes. And the capillary electrophoresis showed that there was sickle cell disease. Her father is a migrant laborer who works as a waiter at a bar in Kerala, and he does that up to 4 months a year. And they're landless; they have no land. So she was admitted, and she was diagnosed as being in crisis, and she was given IV fluids and analgesia, and she was also started on hydroxyurea and folate. Her condition improved, and she was discharged on hydroxyurea. And we counseled her parents regarding the nature of her disease and about the fact that it's a genetic problem that will stay with her for the rest of her life. And we screened her siblings for if they have it as well. And we taught her village worker about what the red flags are regarding sickle cell disease, and we kept her on regular follow. So she was quite regular with medicine. She hasn't had any crises over the last few months, and she also had no fever, no cough, no lymph nodes, no TB contact. But why was she not gaining weight? She was still SAM 6 months later. So uh, on the chest X-rays, well, there was no hilar lymphadenopathy. So there was no reason for us to suspect why that there might be TB. So she wasn't gaining weight enough. So what could be the causes? So uh, yeah, would anybody want to talk about this particular case?
Just a question, Alok. How are SAM children normally treated there in Swasthya Swaraj?
I did not follow your question. I'm sorry.
How are SAM children? What is the treatment protocol for SAM children normally in Swasthya Swaraj?
So we refer them to the NRC at the district hospital, which is the rehabilitation clinic, and they don't go. So
Yeah.
so they brought to the clinic, and we try to give them nutritionally intensive foodstuffs, like we give them RUTF or just locally made therapeutic food, and then we try to see if there's any focus of infection which is causing them to be malnourished, and then we keep them on regular follow-up. So if they go to the creche, then they're routinely monitored, their growth monitoring is done, and they're given nutritional supplements, and their parents are taught about good feeding practices, and we are trying to help them make up kitchen gardens so that they can be fed locally available nutritious foodstuffs. And there are also some parents are taught livelihood skills. So like if especially in her case where her father was only doing 4 months a year of you know migration as a waiter, then he could be taught poultry, so that then if they can have a poultry, small little poultry thing near their house, and if she can get eggs from there. But that's about it. So
Thank you.
like the next slide, I'm going to be talking about malnutrition and about all the various problems that go into uh, malnutrition as a disease state. So, but before that, maybe we can also talk a little bit about sickle cell disease. So,
Yeah. We have
yeah.
Priyansh's hand raised. Maybe he wants to add to this slide.
Great.
Yeah.
Thank you so much. Yeah, can you, Priyansh, thank you so much. Can you please?
Yes, thank you so much for this. Regarding hydroxyurea, I've been working in one of these rural tribal areas in the district hospital of Gadchiroli, and was a very common problem over there in that belt of Chhattisgarh, and then near the east part of Maharashtra. So, and big challenge, the one most common gap that I could find was the underdosing of hydroxyurea, which was quite a bit of challenge, and also counseling for other aspects of hydroxyurea, like they get chills sometimes, and preventing crisis was a big problem for us as well. I'm curious to understand how do you suggest or prefer counseling? Usually what we personally do is, because it's very hard to explain to the patients by weight hydroxyurea. So how do we go about that?
Yeah, that's a wonderful point that Priyansh has raised. Thank you so much for that, Priyansh. So the problem is that these hydroxyurea the drug comes in capsule form. So you've got to open the capsule up, and then suppose the child needs say 250 milligrams. That's easy, because then you can ask the mother to divide the powder in two equal halves and then give each half, you know, so one half today and the next half the following day. Whereas if you got a child who needs suppose 150 milligrams, then it will be difficult to explain to the mother that she ought to divide the powder into three equal halves. And then, so that is one thing. And underdosing therefore also happens because of that, because we don't really have hydroxyurea being dispensed in 250 milligrams as much, or even in smaller doses than that. And the other thing is that we don't really have much of a chronic disease follow-up registry. So it's really hard for mothers to come for routine follow-ups just to take hydroxyurea refills if they feel that their child is relatively well, especially in adolescence, where if they feel that the child is all right, then they don't really follow up, and that leads to an increase in the incidence of crises. So I agree with both of Priyansh's points. Priyansh, do you have anything else that you might want to add to that?
No, so usually just sharing the practice that we do to prevent when we face this issue. What we did was we first thing was we put there was a very much a drug ready reckoner of hydroxyurea for all our medical officers as to be aligning on the same page. So instead of telling them that hey, just take this amount of mg in a day, we just used to cover a number of 500 mg, which is the usual one which we get per month. And then we say if it's 40 kgs and above, for example, on Monday you take one, on Tuesday you take two, on Wednesday you
Okay.
take one, Thursday you take two, and so on. And also then we dispense one local language handout. Of course, we first explain to them and then we hand it out. It's actually thanks to one organization, Sangwari in
Oh,
Chhattisgarh, who
great.
had
Yeah.
made them. Yeah, so we use the same.
Okay. That's amazing.
Yeah.
Then with sickle cell disease, also the other problem is that with families, there are a lot of families who've got more than one child with a diagnosis of sickle cell disease, and that is really difficult for the parents to see so many. Like we've had so many families with 3 or 4 children who've got sickle cell disease, and then there's a big caregiver burden because the children keep getting unwell. They have chronic non-healing ulcers, and there's often children who drop out of school or they miss classes, and there are also many deaths that unfortunately take place. And for all of these things, there is very little psychosocial support that is provided, especially in places where there is no formal access to care, or even otherwise, but especially in places where there isn't a well-run PHC or a well-run community center. So the other thing that I wanted to talk about also is that in other parts of India as well, within a geographical region, we have some subpopulations having a higher incidence. Now in Kalahandi, there's a very big stark contrast. And so what are the ethical implications for if we do intensive screening in such subpopulations? Like, because it's so difficult for people who are routinely getting screened to then find out that that they've suddenly got a new diagnosis, and how do we go about dealing with that? So then there's also one thing that I really want to talk about is about how in some places there isn't much awareness about the fact that there is such a thing as sickle cell disease, which leads to underdiagnosis a lot, and there is poor awareness amongst healthcare workers as well, and in tribal areas. So in Swasthya Swaraj, we have a capillary electrophoresis machine, but in general, it's so difficult to get a confirmatory diagnosis, like to say for a fact that this patient has sickle cell disease. And that is also a big challenge. Then also, as Priyansh was saying, with hydroxyurea, there are so many logistical problems, like the drug isn't available sometimes, and in places that are remote, it's so hard for children who are in hemolytic crisis to get transfusions. And then also one crisis, which is the acute chest syndrome, is quite underdiagnosed, and that is often fatal. So these are some points that I would, if anybody would have any comments about these, then I would be really grateful.
I have a question. Is there any estimates that we have for blood transfusions, because I understand that especially during crisis and many situations, we need to, they come regularly for blood transfusions. Is there any challenges with that, or even checking for other levels of transferrin and so on, which is because of the frequent transfer? Is there a challenges with those as well about the diagnostics? And if yes, then how do you how do you usually deal with the blood transfusion at primary care level, which is relatively quite challenging over?
Yeah, so that's so nice of you that you asked that, Priyansh. Unfortunately, as you're saying, a lot of children who are not even in crisis end up getting routine transfusions because of lack of regularization of, or lack of standardization of treatment protocols. So we've observed that a lot, that children will go to the government hospital and the doctor will purely look at the HB report, and if it's less than a certain value, they're going to transfuse regardless of if the child is in dire need of a transfusion. So we've seen a lot of children who receive 20 or 30 transfusions, even though they weren't really in the need for the transfusion at that point. So patients are not in crisis being given transfusion. And as you're saying, then they get iron overload, and then there are many problems that arise from that. Then also, what the other thing that you're saying is also true, that in primary care, there really isn't any access to transfusions, because there are so many bureaucratic hurdles about if you want to set up a blood bank or even a blood storage unit, then it's not that easy. So uh, I don't really think that there is, in fact, there's a really big role for transfusions in crises, but to have blood transfusions available in remote areas is also not easy. Would you like to add anything to that, Priya?
Um, just thinking. I know it's very specific question, but what do we have like challenges with the desferoxamine or any of the chelating agent for because we often provide that in SCA patients. Just curious to understand. And regarding blood, my reflection would be that it is quite. We have alternative. Innovative transfusion strategies that we have been discussing for quite some years now, and it's as you said, getting that approval is itself a big challenge, and they don't allow rapid diagnostic tests like the unbanked direct blood transfusion techniques, which is actually life saving, but somehow our rules are not really helping out over there. And with the latest technologies, actually the sensitivity and specificity is also high, but still doesn't, unfortunately, has been legalized in India at the moment. And even without that, there are some other, those are more fancier, like drones and all, being discussed in academia world. But again, that's not really seems pragmatic in the rural areas. I see that the unbanked direct blood transfusion by line listing of these patients and also the pre-screened donor pool actually is something which has worked out in some parts of Northeast India, especially in Meghalaya as well and Assam. So I'm curious to explore more on the areas of Rajasthan about it, but I don't have any strong thoughts on how do we solve this concern. It's quite a big challenge for years now, and yeah. So that's the
So
query and the reflection over.
thank you, Priya. So so these are reflections from Odisha, where there is a huge amount of it. Whereas I don't really think that it's as prevalent here. Of course, there is quite a lot of sickle cell disease, and I'm sure that a lot of it may not even be getting diagnosed at this point, but it's not really a public health challenge in southern Rajasthan. Am I correct, Sanjana, madam?
Sorry, Alok, you'll have to say that again. There was a
Ma'am,
call and I had to, yeah.
so actually, we were trying to figure out if in southern Rajasthan, would you say that it's a big public health problem, or maybe not that much? Sickle cell disease?
Sickle cell disease is not that big a public health problem. But yeah, so at a more at a public, at an individual level, yes, we do see, but the numbers are very, very small.
Thank you so much. Thank you. So, Priyansh, thank you so much for all your very insightful comments and if you got some links that you can share so that all of us can read up about all the wonderful stuff that you were talking about in the context of Northeast India, that would be great as well. Thank you. So my last few slides now. I'm sorry that I've gone a little over the hour. Thank you very much, everybody, for your patience. So this only 3 more slides, and all of it is about malnutrition. So we are seeing that there's like a huge incidence in uh, a lot of tribal areas, and it's both as a consequence of disease and as a and something that also causes disease. So it's a vicious cycle of sorts. And in Odisha, amongst the PVTGs, there is about 75% underweight prevalence and 55% stunting, and about 40% of adults are underweight. And so, therefore, this nutritional deprivation is across all age groups, and there are so many interlinked structural factors at play. So, one thing is that dietary diversity is not quite good, and there's reduced food intake during the lean season, and food diversity also decreases, and there's a high incidence of protein deficiency because there's no consumption of animal protein, and their cropping practices are changing quite dramatically. So they used to uh, cultivate a lot of pulses and legumes, but unfortunately not anymore. And amongst females of all age groups, there's a higher incidence, and therefore it's an intergenerational problem. And then there's also traditional rice land races, which were more prone to they were more climate change resilient. Those are being lost to newer rice cultivars that may not really be as suitable as the ones that have been selected for over tens of thousands of years. So our traditional rice land races, they're uh, they're quite valuable in the sense that because of selective cultivation, they've been really honed to be suitable to the local climate and to the local soil. But we're within the span of a generation, we are losing these traditional cultivars, and in their place, we are cultivating varieties that we don't really know how suitable they are to that climate. And there's also loss of forests, and because of that, there is livelihood insecurity because indigenous people in Odisha are really heavily reliant upon forest produce, and there's also non-timber forest produce. So because of how much forest we're losing, we are seeing that people are really losing out on their indigenous livelihoods, and that is causing them to migrate, and then they unfortunately have to seek uh, daily wage work in high risk occupations. And there's also, because in cities there isn't much formal housing for them, they becoming sick when they go to the city. Then finally, there's the question of forest rights, because we're seeing in Kalahandi a lot that indigenous people are losing their land because of dispossession and displacement. And there's also this precarity in their lives, which is further compounded by the rather ominous problem of climate change, because we are seeing that climate change is leading to more famine and drought. And in places where there is no good irrigation, we are seeing that uh, people are really suffering from water scarcity and scarcity of access to good nutrition, which is also something that is leading to all of these diseases occurring in the first place. So that is also something that we should all be thinking about, because we don't really know how the world is going to be in 20 or 30 years, and that's only the span of one generation. But people who've been following indigenous practices for uh, tens of thousands of years are suddenly at the brink of catastrophic change, and are they really prepared to adjust to all of that? So my last slide is about it's a quick summary about all the things that I was talking about. So it's really rewarding to work with the tribal community, and it's so nice to observe their familial structures, and it's so sad that they don't have access to formal primary education or quality health care or nutrition or even electoral rights. And there's very little work being done about hygiene and sanitation. So they don't have safe drinking water. Then there's no local employment. And then the little lands that they do have are forcibly taken away, and in their place, there's mining and hydroelectric projects. So that is further leading to marginalization. So then how do we deliver sustainable welfare? That's my last question to everybody. So it's an open question. How do we deliver welfare that is sustainable during such trying times? It's open for anybody who'd like to answer.
So not a question really, Alok, but the case studies, what they highlighted is the multiple challenges that that a patient faces. And this may hold true at all levels, but it holds true even more for tribal communities where already the barriers are so much more. So I was just reminded of the WHO framework for primary care, and I was wondering if I could just share my screen. I don't know if that is possible.
That is possible, ma'am. I will stop sharing mine. Apita, will you please tell me how to stop sharing mine?
You see a small band over the top of your screen. If you just move your mic, there'll be a stop.
Okay. So you have to go here. Okay, stop sharing. Okay, thank you so much. That's it. Thank you. So, ma'am, will you please now share yours? Thank you.
Yes. Yeah. Are you able to see my screen?
Yes, ma'am.
So this is the WHO conceptual framework of primary care, and where it situates health is, or where it situates primary care is, where there are these three pillars: empowered people, multi-sectoral policy, and primary care. And if we look at it from a different lens, primary care is the only place where these three elements can come together, where we can really work on empowering communities, on addressing the multiple needs, be it related to nutrition, livelihoods. It's not easy, but at least in primary care, we have scope to do that, and working on health. So I just thought that, it connects very well with overall the huge scope that is there in primary care.
Thank you so much, ma'am. Thank you.
Okay. Thank you, Aalok.
Thank you.
Thank you for also posing questions which really needed to be thought over. Any last comments from anyone else? Otherwise, you can close the session. Thank you, Aalok. We look forward to having you for other sessions as well. And the others who have joined too, we would love to have you in other sessions. And thank you. It was very informative, very interesting, and really a nice way to share your learnings through case studies. I think interesting.
Thank you so much.
So, yeah.
Thank you, everybody who
Thank you.
listened to me patiently. It was very nice of all of you to have come. Thank you very much.
Yeah. Okay.
Thanks.
you.
Bye, everyone.
Bye, everybody.
Bye, everyone. Bye. Thanks, Aalok.
Bye.
Thank you, everyone.
Thank you.